Good afternoon, everyone. Thank you for joining us today and welcome to our Hepatitis B Echo session. My name is Anusha Qureshi, and I'm one of the public health program coordinators here at the Hepatitis B Foundation. I'd like to welcome you to today's session. Today we have Dr. Amy Tang, who will be speaking with us on perinatal hepatitis B and prevention strategies and hepatitis B in pregnancy. Dr. Tang is based in California and is the Director of Immigrant Health at Northeast Medical Services, where she manages the hepatitis B clinical programs. She's committed to addressing immigrant health disparities and issues such as viral hepatitis. We are also honored to have Kurt Palumbo, who will be sharing with us a case presentation today after the didactic session. Before we begin, I'd like you to please introduce yourself in the chat, just your name and affiliation or institution. I'd also like some of the providers and advisors who are on the call to introduce themselves. I'll start with Dr. Torgerson and then Dr. Finkel.
Hello, everybody. I'm Jessie Torgerson. I'm an infectious disease physician at the University of Pennsylvania, where I run our viral hepatitis program. It's great to be here.
Hi, everyone. I'm John Finkel. I'm a hepatologist at Thomas Jefferson University Hospital in Philadelphia. I run our viral hepatitis center here at Jefferson. Nice to see everybody.
Katie, if you would like to introduce yourself as well.
Hi, everyone. Sorry, I was trying to do my chat. Good afternoon. I'm Katie Wynn, physician assistant at DVCH, Delaware Valley Community Health, which is an FQHC in Philadelphia.
All right, thank you so much. All right, Dr. Tang, over to you if you would like to start sharing your screen, please.
Yeah, thank you all for having me here. I know this echo has been pretty well established for a couple of years now, and I used to run an echo in the SF Bay area, and then also previously when I was in New York for perinatal specifically. Um, I'm sure you've had a lot of talks before. I'm not sure if you've had a talk on perinatal management, but hopefully you will learn something new. There are some more recent updates that I will be presenting today. Okay, so let me see if I can get this to work where you see. I think I need to swap these. Okay, now do you see just my slides? Okay.
Yes.
All right. So I am a primary care internal medicine physician by training, but I have a lot of experience in managing hepatitis B programs in community health settings. I used to work at Charles B. Wong Community Health Center in New York City, and then I moved up back to the West Coast and primarily based in San Francisco at the moment at Northeast Medical Services. And both of these community health centers have served high risk Asian immigrant populations where every year we would have a significant number of pregnant women with hepatitis B. And so at both centers, we ran hepatitis B mom programs. And when I came to NEMS, I established the Hep B Moms program here. So after I go through some more clinical management, I'll talk about that. But I just want to start off. I like interactive talks. And so just some questions for you to start thinking about. What mode of transmission is responsible for the majority of chronic hepatitis B virus infections worldwide? Actually, and you can drop your response in the chat, although I don't think I can see the chat right now.
We have a lot of people in the chat saying it's C, mother to child.
That's right. That's right. Yes. Mother to child transmission, especially in Hep B endemic regions, is the number one cause for chronic infection. And another follow-up question to that is hepatitis B infection during infancy is associated with what % chance of developing chronic Hep B infection as opposed to acute?
So we have most people saying it's D, 90%.
That's right. So very high chance if an infant who is relatively immunosuppressed or a weaker immune system is exposed to hepatitis B infection will go on and develop a chronic infection. And so this is why we have perinatal programs in the US that spend a lot of resources on ensuring that these mother to child transmission cases don't occur. Because once you have a chronic infection, that's when you worry about morbidity, mortality related to liver complications like liver cancer, liver cirrhosis. So, um, in terms of Hep B elimination, the goal for this talk is really for you to understand your roles as healthcare and public health providers in preventing new Hep B infections for future generations through comprehensive perinatal management of women with Hep B or pregnant persons with Hep B, their families, and their infants. And so specific objectives depending on, what your role is. For any obstetricians on the call or those who work with pregnant women, we want to make sure we identify those who are surface antigen positive through universal screening during pregnancy and linkage to care and vaccination if they're susceptible and at risk. If you work in the adult medicine space, identifying those who are surface antigen positive who need antiviral treatment during pregnancy. In all the places that I've worked, we manage as internists or primary care. We don't necessarily, it's pretty straightforward, doesn't necessarily need a referral to specialists, but it depends on your practice setting. And then for pediatrics, the role is to really ensure that all the infants are getting their birth dose, but also if they're born to a mother who's surface antigen positive, that they get their immune prophylaxis with the Hep B HBIG. And then that they also receive testing close to a year to make sure that they have immunity and that transmission did not occur. And then lastly, for those who work in a public health capacity, linkage to care for those who need treatment and also household contact testing has been really a fundamental part of these perinatal programs because those who live in the same household are very high risk for having Hep B as well. So this is a perinatal management algorithm that we had developed, and it's in the Hep B Online simplified guidance. For those who aren't familiar, there's a link on the corner. But the purpose here is really that we identify and evaluate all pregnant women with Hep B infection and provide appropriate vaccination of the infants to reduce mother to child transmission. And I'll go through all these steps through the subsequent slides. But this is an algorithm that you can reference if you wanted to have something on your desktop or at your desk. So a note about screening. So USPSTF, CDC, ASLD, I'll recommend that women get tested in every single pregnancy, regardless of their prior Hep B status. So even if they were previously tested and known to be surface antigen positive, we would want to retest them because sometimes they may clear their surface antigen. If they're previously negative, we'll still retest them just to see if they're positive, just because this is such a high risk transmission scenario. Ideally, women would get tested in their first trimester, but understandably, some present later in their pregnancy. And so it's really as soon as they can get their prenatal labs done. And just to kind of emphasize, this is not risk-based. It's not just mothers who are from Hep B endemic regions. It's really all comers. All right. So this is the CDC algorithm. And what I want to kind of focus on here is the vaccination guidance. And so if somebody is surface antigen negative, we actually test with the triple panel. I think here the focus is the surface antigen, but you can't really know if someone is truly susceptible unless you also check the core antibody and the surface antibody. So that is my recommendation for any type. Oh, did my slides just disappear?
Yes.
Oh, one moment. I'll just try to keep talking. So that is the recommendation for general adult screening to do the triple panel, and that's what we also do in our with our OBGYN department for prenatal screening is checking the triple panel. But if somebody is susceptible, then we can vaccinate during pregnancy, and one of the updates is that Heplisav recently received FDA approval for use during pregnancy based off of some safety data that showed that it was safe. And I know that pregnant women these days are really bombarded with a lot of different vaccines they have to get, especially in more recent years with COVID, but also RSV. Our own OBGYNs have expressed some, I think, challenges with having all of these discussions about all the vaccines they need. So, vaccinating during pregnancy is really recommended for those who are at increased risk for Hep B infection. And that includes women who have any Hep B sexual contacts or household contacts, those who are immunosuppressed in any way or have HIV, have any history of STD infections, multiple sexual partners. Apologies, I've been having some computer issues. I'm not sure if it might be better for us to transition to the case for a moment because my computer was a bit glitchy earlier this morning. Okay, actually, sorry, it's restarting now. Okay, I have it now. Mm. All right, you see this again?
Yes, we do. Thank you.
Okay, good. So now we can either provide the 3-dose Endrix or Combavax or the 2-dose Heplisav. I think it makes more sense if someone is truly high risk to administer the 2-dose Heplisav, which can just be completed in 1 month, the 2 doses 4 weeks apart. So that is an option now if you guys carry the vaccines. Otherwise, if you start the 3-dose, it takes at least 6 months to complete it. And for those who didn't get vaccinated or incompletely vaccinated and are at high risk, they should be retested at the time of delivery when they're in the hospital. Okay, so question, why are infants born to surface antigen negative women also recommended to get the Hep B vaccine birth dose, which is given within 24 hours? The options are here. A is to protect the infant from Hep B transmission by a caregiver or household member, like the father or grandparent. B is sometimes hospitals misidentify or misinterpret the mother's Hep B lab results, like mixing up surface antigen, surface antibody, et cetera. Or C, some women do not get tested for Hep B during pregnancy, or the results were not properly reported to the hospital, or D, all of the above.
We have people saying D in the chat.
Yeah, that's right. All of these are reasons, and that universal birth dose is recommended for all infants. Follow-up question. So besides the the Hep B birth dose, what else is given specifically to women who are born to surface antigen positive mothers within 12 hours of birth? So is it A, HBIG, or B, a dose of injectable Hep B antiviral, or C, the Hep A vaccine birth dose, or D, none of the above? Um, I'm actually going to move a little bit faster, I think, because I lost a little bit of time, but I think I've mentioned HBIG. And so if you just give the birth dose, it's estimated that it can reduce transmission risk by about 75%. And if you give the HBIG, it can prevent transmission by an additional, about 20%. So these are all estimates, of course, based off of the mother's viral load, but getting to the two vaccines is much more effective, especially for those infants who are at much higher risk. Now, PVST, which is post-vaccination serologic testing, is something that's part of the care for tracking whether infants achieved antibody immunity or if there was transmission as evidenced by a positive surface antigen. We recommend testing for this between 9 and 12 months of age and not too early. Sometimes if you test too early, you could have a false positive surface antigen. I think that's a known thing maybe for some of you who are doing screening and vaccination generally, that if you're going to vaccinate, you need to wait like at least a month after the last dose of vaccine to screen somebody because their surface antigen could be falsely positive. And so that's why we make sure there's a delay. And then unlike routine testing and Hep B screening for adults or asymptomatic individuals, we actually don't include core antibody when we're doing PVST because you can actually get false positive core antibodies from passively acquired from the mom up until 2 years of age. So if you, for some reason, do want to check core, I would wait until after 2 years old. All right, so when you do PVST, if you find the infant is surface antigen negative, you want to take a look at the antibody titer. Although maybe you're in a place that does qualitative, and that's fine. So if they have a positive antibody or a titer greater than 10, they have protective immunity, and you do not need to recheck in the future. To make sure that they've achieved it. There are some people who have what we call waning immunity with time. So the titers will decrease, but they have an amnestic response if they were re-exposed to the virus. And so we do not kind of endorse that you need to recheck in the future if they have confirmed immunity at this time. Now, if their titer is less than 10 or if they have a qualitative negative result, then you can revaccinate the infant and then retest them. And again, just to confirm to see their response. There is also an option to just do a booster in this case and then retest. And if still they haven't achieved an adequate titer, then you would just finish off the vaccine and then retest again. So there's two options for this. Of course, if you find an infant who's surface antigen positive, they should get appropriate follow-up. Now, there is such thing as immunoprophylaxis failures, and that's especially if the mother has a very high viral load. So the infant could get the birth dose plus HBIG, but still end up surface antigen positive at their PVST. And this is the reason we do this extra layer of checking mother's viral load status. So follow-up questions. A pregnant woman with Hep B DNA greater than what level are recommended Hep B antiviral to prevent transmission to their infants?
We have C in the chat.
Okay, great. Yeah, this group is very knowledgeable. So there's this is all based off of a large retrospective study in 2012 of 869 Chinese mother-infant pairs, and where they observed that immunoprophylaxis failures occurred in infants that were born to moms with Hep B DNA as low as about 200,000. And so that's why women who have a viral load greater than 200,000 during pregnancy are recommended to be initiated on antiviral. approximately 10 weeks before their due date. And so we have a window of 28 to 32 weeks of pregnancy. This is a study that I did when I was at Charles B. Wang Community Health Center in New York, where we had a lot of pregnant women with Hep B. And we wanted to see how common it was for women to kind of reach this high-risk threshold. We saw that actually 1 in 5 pregnancies among our mostly Asian American population with chronic Hep B were considered high risk for mother-to-child transmission because of this high Hep B DNA. We had more than 1,000 patients in this study, and it was a 10-year period. Another interesting kind of thing that came out of this is that I think a lot of people will also look at e antigen because it's reflective of being in a high replication phase. But there are also women who are e antigen negative who have a high viral load. And for this population, it was about 7% of those who had a high viral load were e negative, and majority of them were still e positive. So e positive can be a surrogate for those who are at higher risk, but it's you also need to consider those who are e negative who may have some mutations in their virus that allow such high replication to occur. So indications for antiviral treatment to prevent vertical transmission. So as I mentioned, we do recommend treatment if viral load is high, and tenofovir disoproxil fumarate, or Viriad, has been the go-to medication because it has a long-standing set of data that's indicating that it's safe and efficacious. Now, there was a recent meta-analysis done by Calvin Pan and his team that showed that tenofovir alafenamide, or Vemlidy, is also just as effective and likely safe for use during pregnancy. I'll show a little bit of some of the safety data to you in the next slide. So if you are going to start antiviral, you can choose either of these medications. I personally still tend to choose TDF, or tenofovir disoproxil fumarate, because it has more of a safety record. But if there is a reason that you would prefer to choose TAF, or tenofovir AF, then you can also choose that. So again, the timing really depends on whether it's like a singleton pregnancy or a multiplet pregnancy. So I have taken care of patients who are having twins and triplets, and they do tend to have planned deliveries that are sooner. And so if that's the case and they're high risk for transmission, you'll want to initiate the antiviral sooner. And also, again, Calvin Pan and his group had some data published earlier this year that showed that earlier antiviral treatment is also safe for the mothers. Okay. So in these cases where you're really just initiating antiviral because of high viral load to reduce transmission to the infant, the mother can safely discontinue their antiviral at delivery. There used to be recommendations to kind of have them take it for a few months postpartum to potentially avoid this period where women may be more likely to have some hepatic flare-ups. But at this time, the consensus is it's safe to stop during pregnancy, but you will want to monitor for post-treatment flare. And the recommendation is every 1 to 3 months for 6 months. This is the meta-analysis that I had mentioned, if you guys want to take a look at this later, that showed that TDF and TAF are equally effective, and that TAF is relatively safe. And here's the data I think I wanted. I think safety is really the main thing that we think about, both for mom and for baby. And there is this there's this antiviral registry that is called the Antiretroviral Pregnancy Registry that focuses on meds used for HIV or Hep B co-infected mothers. And data from that shows that if you take a look at those who were taking these medications during their first trimester, that the prevalence of birth defects for TDF regimen was slightly lower, 2.58, and for TAF it was 3.66. And then if we measure that up to kind of the general baseline or background rates of birth defects, it's anywhere from 2.7 to 4.2, depending on which registry you're looking at. And so this was part of their decision to say that it does seem relatively safe and it can be used as an option if needed during pregnancy. Monitoring for flare postpartum. So I typically do 1 month, 3 months, and 6 months. And of course, if it's very elevated at any of these times, I will potentially do it sooner. I think if you wait until 3 months, it's a little bit late because some of these elevations can occur earlier. Now, what if it is elevated? And what is elevated? So I use 100 as a cutoff. There are some recommendations out there that say if the ALT ever gets to 10 times the upper limit of normal for women, which is greater than 250, then you should go ahead and restart antiviral. If I see it greater than 100, then I'm going to monitor them closely and check some other some LFTs along with that. I have seen some mothers who maybe will go up a little bit to like 90, but then they come back down right away, and then there's just nothing to do, and it's fine. So sometimes some mild elevations happen. I think it's very, very rare for there to be significant liver injury or decompensation. But there are thresholds for restarting. Now, every patient who's newly diagnosed with Hep B should also just generally be evaluated for whether they need to be on long-term antiviral for their own for themselves. So I want to caveat and say there are many new guidelines coming out for Hep B treatment. WHO came out last year recommending everyone F2 or higher, significant fibrosis or elevated viral load in ALT. And then EASL came out this last weekend, similar but slightly different. So they instead of F2, they said anyone with advanced fibrosis, which is F3, or cirrhosis should be treated. And then you look at Hep B DNA and ALT or other factors like family history. And so I put this together as kind of a summary of some of the more recent recommendations and also just a form of simplification. And so take it as you will. I am actually working with a work group on updating the simplified guidance that's on Hep B Online to kind of incorporate some of the new guidelines that have come out. And so that's forthcoming. But this is some general guidance that you can follow for who should be on the antiviral for long term to avoid liver complications. And then regarding breastfeeding, breastfeeding is encouraged for women with chronic hepatitis B. Hep B is not transmitted through the breast milk. However, women should be mindful if they have cracked nipples during pregnancy, which is really quite common. I think there should be some reassurance that since the baby received HBIG, that can provide some protection for the infant from getting hepatitis B for even up to 6 months until they finish their vaccine. So just normal nipple care, maybe hold off until, pumping until it's healed and, getting advice from pediatrician or the OBGYN about that. And also women breastfeeding while taking tenofovir has not been linked to any adverse effects for the infant. Okay, I don't know if we have time to go over like our Hep B Mom program infrastructure. I can stop here.
No, we can.
If we do. Okay. So I have managed 2 Hep B Moms programs, one in New York and one in San Francisco. And this is kind of the framework of how these programs work. So because we're in a community health center, we typically have OBGYN and pediatrics and adult medicine all under the same roof. And so the program is usually kind of glued together by some sort of Hep B care manager who will kind of use tracking reports to identify those who are surface antigen positive during their pregnancy, engaging them in some education, linking them to a Hep B provider within the adult medicine department, and then also collaborative meetings with like a pediatric, so OBGYN team lead to discuss cases, make sure that the moms are getting appropriate care. This is a resource that we put together for patient education. We have this in a couple different languages, I think at least in Chinese and Vietnamese. But it's like a roadmap of what both the mother and the infant need to kind of do, starting as early as the first trimester of pregnancy until about a year of life to ensure that Hep B transmission doesn't occur. This is just a snapshot of our EHR care manager's template and some of the education that she goes over. She also just takes time to go over things like family history and whether individuals have been tested. We have a household contacts testing program where we offer free testing for family members or household members that haven't been screened for Hep B yet. So some take-home points. This is really kind of similar to the initial slide that I showed, but ensuring that we can prevent mother-to-child transmission really requires a team effort between obstetricians, Hep B providers, delivery hospital, pediatricians, and local health department, and that we are exchanging accurate information. This happens a lot where some information is not transmitted and there are these near misses. And so just kind of be very mindful of that. We're testing all women during pregnancy, regardless of their prior status. We're checking their viral load during their pregnancy and offering antiviral treatment if it's above 200,000. All infants are getting birth dose and HBIG and post-vaccination serologic testing to ensure that they are protected and linked to care if needed. And the health department also plays a important role in ensuring these things are happening and also getting people tested who are also very high at risk. I want to just make sure you know about this resource on Hep B Online. This is the simplified guidance and the algorithm that I had shown on one of the earlier slides. There's also some CME and some other clinical scenarios that I think are helpful as learning cases. So that's all I have. Yeah, I'm happy to answer any questions if there's time.
Thank you so much, Dr. Tang, for that insightful presentation. If anyone has any questions, please put them in the chat or come off of mute.
You mind if I ask a quick question, Anusha? Thanks so much, Dr. Tang. I was curious if you have started to incorporate at all the data that Dr. Pam presented last year about starting treatment in the second trimester and preventing HBIG need, or has that not been so much in the US yet?
Yeah, I think that's kind of more relevant for low resource settings if there's HBIG is not available. And I think the guidance around that was if you're in a setting where you anticipate that HBIG will not be available during delivery, then you can start antiviral earlier. And so at our hospitals, HBIG is readily available. And so we'll just start it, 10 weeks before delivery.
Thanks.
Mm-hmm. Thank you.
If I could ask a question, and Dr. Finkel stole my question as well. So that was as you talk about simplified guidelines and Dr. Pan's work. Do you see a specific direction for simplification of Hep B treatment in pregnant people? And if so, do you expect that to change our threshold of treatment initiation and timing?
Oh, in pregnant people, actually, so I don't think there will be any changes simplifying pregnant treatment. I mean, so right now it's 200,000. If it's over, you treat. If not, then you don't need to. I don't anticipate necessarily a simplification of that. I think a lot of it is balancing the fact that a lot of women really prefer not to take antiviral. Like people are very sensitive about not taking medication during pregnancy unless it's absolutely needed. So a simplification such as, oh, everyone who has Hep B and is pregnant should be on antiviral, I don't imagine that happening because I think there'd be a lot of pushback and people are like, well, what's the relative benefit and risk? But I think that Calvin Pan's new data is very useful in certain settings that don't have HBIG, but I think that in the US where it is readily available, I don't see that part changing very much. But we are in much need of a simplification for treatment algorithms in general for like non-pregnant adults and also those who are pregnant and at risk. And there are many different guidelines out there right now, and I think it would be great if we could come to a consensus.
Jesse, were you thinking more about with simplification of treatment guidelines generally that more people might be on antivirals when they get pregnant already?
That's what I was anticipating, particularly if you, look at the Mount Sinai simplified guidelines and thinking anybody over 30 and viral load over 2,000. I would anticipate we're going to see people who are coming into care or OB care on treatment and, with the antiviral regimen or registry demonstrating safety. Will we extrapolate that? Will we continue those therapies? What sort of the guidance that you think will come out of that with these hopefully expanded treatment guidelines and more uptake in younger people with hepatitis B?
Oh yeah, I didn't know about Mount Sinai. So you're saying they have their own guideline for treatment of non-pregnant adults where if they are 30 and have a viral load over 2,000, that they're recommended treatment?
That's what they're positing as one mechanism to simplify treatment to improve uptake among those who would be eligible for treatment, and not assuming that ASLD will assume the same liberal approaches, but certainly thinking about still within the reproductive window, will we see more people coming into care on TDF, TAF, and Tecovir, and how you think those people may be managed in the peripartum period.
Yeah. It is interesting, like in China with the China guidelines, which is probably the most permissive. So they do say anyone over 30 with a detectable viral load would be on antiviral. And then and then if they're under 30, it's like if they have elevated fibrosis or if they have some comorbidities and things like that. But it's almost everyone. And I imagine in China, there are a lot of women who are who are pregnant and already on antiviral. And I guess you could say that that will simplify things in a way. I don't know how China plans to roll it out, to be honest. There isn't much of a primary care infrastructure. I think still people um, are seeking care when they have symptoms, and there are some like community level like health access sites, but they operate quite differently from the US. So I think in theory, with the China guidelines having very low thresholds, I'm very interested in seeing how it ends up rolling out. If there's going to be some sort of public health program that kind of tries to implement it, or if they're using their existing infrastructure, I think it'd be really challenging.
I did have one question for you, Dr. Tang. How do you address any loss to follow up for women postpartum? Like, let's say they give birth and maybe they're no longer in the program or they don't stay connected to care as often.
Yeah, the postpartum period is a really tricky time. I think a lot of women are so focused on caring for their infant and not thinking much about their own health. So so at NEMS, we have a Hep B program with community health workers that will re-engage any individual, regardless of if they were recently pregnant or not, just any of our adult population who hasn't had a viral load in over a year and they're in our Hep B registry. And so we send letters, we make phone calls, try to schedule them with appointments with their PCP. We do the same thing for those who are due for like liver ultrasounds, because that's another aspect of chronic Hep B care that people often like fall off the monitoring path. And so similarly, if people are overdue for their ultrasound by a year, we also send them a letter and re-engage them. So that's why we have other aspects of our program that ensure that these women who are recently pregnant are still getting follow-up. We have Epic. We switched to Epic a few years ago, and we developed a registry that's based off of either a positive surface antigen or viral load in the last 3 years, or an ICD code for chronic hepatitis B. And being in the registry means that we can develop for those who work with electronic health record systems out there and do modifications. By having a registry, we can develop healthcare maintenance reminders and care gaps. And so like if this patient is coming into care, then the provider can see, oh, they're due for their viral load, they're due for their ALT and all of these types of things. And if they're not coming into care, then our CHWs are reaching out to them. So those are our mechanisms of making sure that our chronic Hep B patients are being followed and getting recommended care.
Yeah, those are great strategies. Thank you so much, Dr. Tang. Does anyone else have any questions for Dr. Tang? Okay. Thank you again for your presentation. If you do have any questions, please feel free to put them in the chat and we'll keep monitoring it. We'll move over to our case presentation now. Kurt, if you would like to introduce yourself and then share your slides as well.
Sure.